Good evening, everyone. My name is Agina Makwabe. I'm the Chief Medical Director, AHN, and consultant physician and nephrologist in Tanzania. So I would like to welcome you all to today's AHN Education Nephrology webinar. And this is series number 80. The topic today is a very interesting topic. It's vascular access surgery, building the capacity across East Africa. And I think we all know, for those who are coming from East Africa, that getting people who can perform fistulas has been an issue. So we need to build capacity across the board in East Africa and Africa, of course. So today it will be a panel discussion, and we are like to have our discussants from Kenya, Rwanda, and Tanzania. We have had Dr. Green and Dr. Jerry, they are already in. So I'll be moderating this session together with Nick Hill Pereira. Nick, have you joined? And Dr. Frida Moore, who is a consultant nephrologist and pediatrician working with the Africa Care Network in Tanzania. So Dr. Lloyd, are you going to start this conversation, or Dr. Green or Dr. Jerry? Anyone can start.
Well, I can start. Joel, is that okay with you?
Yes, that's fine.
Okay, well, I'll just give a few opening remarks, and then I want to hear what you guys have done. We learned a lot and made some mistakes, and happy to learn from your experience. Last October, Nick Pereira, the CEO of AHN, and I had a conversation in Kijabe, possibly got arranged, and he proposed that we have a training session for local general surgeons in Kenya. And no promises were made at that time, but by Christmas, we had 2 weeks of a fistula training camp, sort of roughly laid out, and was going to be at 2 different sites, a week in each. And then as we got closer, it turned out to be Chogoria only, with enough work there apparently to keep us occupied. And Samaritan's Purse was involved providing logistics, which was extremely helpful. And I just can't say enough about the support that we got from them. We had, depending on how you count it, we basically trained 5 or possibly 6 people to do these procedures. And I would say, hi, John, I would say 3 of them are solid independent fistula operators now, and 2 of them likely are. 2 of our surgeons from Kijabe were only there for 3 operating days, and they're both good operators. I had operated with both of them in general surgery circumstances before, and both of them caught on to it very well. So Rich Davis, who's one of those from Kijabe, has signaled us an hour ago that he has to be operating this evening. So unfortunately, he can't be here. Anyway, our goal was to train surgeons to be able to do AV fistula surgery. And we realized early on that there was a disparity between training surgeons and simply making fistulas. So I'll leave it at that for now, Joel, and we'll get into some details, but maybe you from Rwanda and who's ever here from Tanzania can chime in at this point.
Sure. Let me start my video so it's not just a picture of me talking. Hi, Joel Green. I'm a surgeon in Grand Rapids, Michigan, and I travel periodically to Rwanda to work at Kibogora Hospital, which is a rural mission hospital. There is a full-time general surgeon there named Ronald Tubasimi, who received his training at the PAX Ethiopia program in general surgery. So he's a great general surgeon, very skilled, and I've been privileged to work with him over several years. One of my partners from Grand Rapids also travels periodically to Rwanda. We are both transplant and AV fistula surgeons, as well as general surgeons and trauma surgeons. So it was last year, probably about October, November, we got in contact with Nick and Lloyd, and through emails, kind of hatched this plan that we would start to train Dr. Ronald in AV fistula surgery. You sound like you were much more organized compared to us as far as organizing a camp and and having many surgeons there. But we decided to take it just step by step. And Dr. DeYoung, my partner, traveled in December and January to Rwanda and spent a portion of his time evaluating with ultrasound to find acceptable candidates for fistula creation, and then performing probably 7 to 10 fistulas with Dr. Ronald. And he found Ronald to be very skilled at that. And as you mentioned, a good general surgeon becomes a good fistula surgeon without a lot of extra training. I visited in February, and then another doctor, Dr. Praise from Mississippi in the US, also visited in end of March. And each of us has met and evaluated patients with Ronald, and then basically allowed him to do the fistulas, just sort of with our supervision or help if it's a particularly difficult case. But we found the same thing. I think we're just kind of learning. Anybody who does fistulas for a while realizes how frustrating they can be. Failures to mature or need for assisted maturation. Those are going to present some serious problems for us, I think, in the coming days. So yeah, interested to hear the Tanzanian experience as well.
Dr. Francis, Dr. Jonathan, most welcome. If you can unmute and talk. And Dr. John Kaney also was part of the camp. Most welcome. Please unmute and feel free to speak. Dr. John Kaney.
Thank you. Thank you. I don't know if you can hear me.
Yes.
Yeah, we can hear you.
Okay. We were having issues with the network here where we are. Yeah, we participated in the camp. I think going into a camp where you have 20, 30 patients was, I think, was a good experience for us to learn to do AV fistula. And we were glad to be on that camp.
Dr. Francis, Dr. Jonathan, would you like to say something? Tanzania? I did call Dr. Moses, but I think he must be busy. That's the reason.
Yes, Dr. Lloyd, thank you very much for organizing this meeting. And I think the experience that we are hearing from other colleagues is quite interesting. So I think it is a good thing now with Dr. Moses and his colleagues who are vascular surgeons coming in. That has shaped things a bit, because initially we had only one vascular surgeon who was doing fistula in the entire country. So that was quite challenging, considering the fact that we have a population of more than 60 million people. So having only one surgeon saving this huge population was quite challenging. So yes, indeed, Dr. Moses and his few colleagues have changed the way things are being done, but I still think that the needs are quite enormous, and I do not know what is the experience in other settings, because the surgeons that have been doing our accesses are vascular surgeons, and you know that the workload of vascular surgeons is quite heavy. And so I'm not sure I would really want to learn from the US experience. Who are the people that are doing fistulas? And if it is possible to train and to impart these skills to general surgeons, I think that might be a better way of going, so that we can have a big number of people that are able to do fistulas. And if we really have challenging ones, then we can send those to vascular surgeons. I think that will be the game changer in our case, given the huge population that we have in Tanzania and the needs that we have at the moment. I'm also quite happy that at KSMC, they're also trying to train people, and they've already started doing fistulas, and somebody is doing that in Dodoma as well. Thank you.
If I can comment, Dr. Francis, thanks for that, that call to general surgeons. In my town in the US, the vascular surgeons mostly manage peripheral vascular disease. And there are a few of them who do AV fistulas as well, but the vast majority of the AV fistulas are done by general surgeons in my town. So I think that varies regionally, and you may find some places where only vascular surgeons do it, but it is definitely a skill that a general surgeon can master.
Okay, so I'm quite happy with that, and I want to believe that the best way, the sustainable way of doing it is for us to see if we can build capacity in the all the surgery resident program, so that this could be a skill that can be acquired during residence program. I mean, this is the long-term plan anyhow, and we should think of ways of investing in that. Yeah, thank you.
Yeah, so I was also thinking about the role of nephrologists in creating fistulas, for example. I've seen in other areas, interventional nephrologists are the one who are actually creating fistulas. In our side here, due to the a lot of constraints in terms of human resource and finance. We don't have interventional nephrologists who can do that. But I know there are nephrologists who can do it, who are not interventional nephrologists. Can they be trained? Is it that possible? That I would like to have, to hear from Dr. Jerry and Dr. Green and see what's your experience in the other areas.
I think anybody with reasonably steady hand and reasonably good eyes could be trained. It's even conceivable, and I'm not recommending this. You could even train a technician. Probably my wife could learn how to do this in a week or two. So I don't think there's any real magic to it. And I agree with you completely. Training general surgeons is the way to go, because it might depend to a certain extent on the personality of the individual doctor, but any general surgeon can learn how to do this if they want to be, if they want to take the time and endure some of the frustrations. I'll make some more comment. So we try to prioritize the teaching rather than the numbers of fistulas we made. Our experience with ultrasound, even though we realize that ultrasound has a real role in this, you know that in the States, everyone has a preoperative ultrasound. If they've had a fistula before or not, everybody gets an ultrasound. And any hospital that has an ultrasound technician and a general surgeon, they could have a 30-minute meeting and come up with a diagram, and such blank diagrams are online that you can find. The technician could be trained on how to measure veins and which segments of patency you're interested in. We did come up with a PowerPoint, actually two, but the first PowerPoint for this fistula camp, and we're happy to share this with anybody. Some of you have seen the first hour PowerPoint 2 weeks ago at this fireside chat. So we're happy to share that with anybody else. But I think that's a very good starting thing. We didn't have a great deal of help from ultrasound during our camp. Although we had what you guys call the butterfly ultrasound, which is essentially like a sonocyte to us, I don't have a great deal of confidence in my ultrasound ability. Almost everybody is younger than I, and thus is more experienced using the ultrasound in trauma in the ER and elsewhere. So you all will probably use it more. We primarily taught a tourniquet examination and an inspection of the arm veins to make our clinical decisions about where to make our fistulas. And we sometimes use ultrasound, but we did have 2 operations which were thought to be just explorations and closes because no suitable vein was found. And in fact, that's what both of those were. On one, we saw no vein at all. Actually, on both, we saw no vein at all with the ultrasound, but none of us present was confident enough in our abilities. In one of those patients, we found a big fat cephalic vein that was totally occluded, and we didn't even see that on the ultrasound at all. So the introductory PowerPoint, which is about an hour, is available to anybody, and that could be done through Lloyd. He has it already, actually. We presumed from the beginning that the general surgeons involved in this training had no experience with vascular suturing and no experience with a Castroviejo needle holder. And so I do think that some practice prior to a camp with practice blood vessels would be very handy and would save time and possibly some frustration. And I did look online, and the Chinese $10 practice kits are again available on eBay, but they won't ship to Africa. So, you know, anybody who's interested in having one of those sets, it seems that maybe we can get that into. It's just a little plastic rubberized blood vessel kit that's very handy in teaching anybody. A couple more comments and then I'll give up for a while. Some of the things, when talking to the patients, we found it very helpful to, in a very routinized fashion, mention the possibility of problems. And we use the term for our memories, biosin, B-I-O-S-I-N, standing for bleeding, infection, occlusion, swelling, or a nerve injury. That's how we remembered that. And the instruments that I brought, some of them were of great quality, but some of the Pakistani instruments really failed on us. By the 9th day of work, perhaps the 12th or 14th sterilization, some of these instruments were rusting already. And that was a big disappointment. And continuation of availability of supplies after we left is a matter of concern. Papaverin, heparin. Heparin, I think, is readily available because there's a dialysis, if there's a dialysis unit. But 7-O-proline, 4-O-silk seem to be in short supply, headband magnifiers, and eye spears. And I'll give it up to somebody else right now.
Dr. Green, how do you manage the supplies, like what Dr. Jerry mentioned?
The supply issue is definitely a problem. As we send visitors, we have some avenues through in the U.S. that we can have charitable donations of things like sutures. Vessel loops is another thing that we ran out of very quickly, which are nice for retracting the vessels. And then we've also just purchased some equipment, as you did, I think, Dr. Jerry, online, and brought it with us. There are some equipment companies that make charitable donations. I have not yet had contact with any vascular surgery equipment companies, but in other situations, like for instance, the Thompson Retractor Company donates refurbished retractors. And so my plan is to contact some of these equipment makers and see if they have a charitable arm where they would donate some of their refurbished equipment. To your point about preoperative evaluation, I think the ultrasound is very important and should be taught. The problem we ran into was that many of these patients were so dehydrated on the day we ultrasounded them. Many of them had just had 3 liters, for instance, taken off in dialysis the day before, and their vessels were tiny. With that said, we brought some of them out to Kibogora Hospital. The way we do it, we met most of the patients in the capital city and then brought them to Kibogora Hospital for the actual surgery. When we brought them to Kibogora Hospital, we had the anesthesiologist perform a supraclavicular block, which significantly dilates the vessels. And we found the vessels looked much better on an ultrasound after the block was placed. So I'd love anyone's suggestions on how to better prepare the patient for the preoperative evaluation. One thing we talked with Dr. Joseph about was the option of bringing them in and on the morning of maybe giving them a little IV fluid or having them drink a little extra the night before so that they would have a little bit of an increased fluid status and maybe dilate some of their veins so that we could see them better. I'm not sure how that will pan out.
Thank you, Dr. Green. I'm sorry, first of all, you see, normally the practice we have for our patients here, you find, most of them, they are not dialyzed 3 times a week as prescribed. So the moment this patient comes, so you want to remove as much fluid as possible because you are not very sure he's going to come, 2 days later. So that's why when he comes there, so much fluid is removed as much as possible. But if you had talked with this team of ladies that we met last time, actually we had prepared these patients, and we actually put them on dialysis after they have been evaluated, and we didn't have any problem. In fact, 100% of the patients we evaluated were they qualified for vascular surgery at the time actually that was chosen. So I do agree with you. It is very important to prepare these patients. It's not even before surgery. Even after surgery, you need to have their veins filled for early maturation of the fistula. The only problem is that here it has not been a continuous process. We've been having people coming once in a while. From the Strasbourg team that has been very helpful. They come and once a month and they do quite a number of patients, and those patients already on fistulas that we had, they are the ones who had done them. But I agree with you. It is very important, to have these patients well filled, the vascular system well filled, even post-op until the fistula matures. I agree with you. It's very important.
Yeah, I have lost many fistulas in the U.S. because of hypotension during dialysis. So especially one that is with smaller vessels, it would be very important to limit hypotension during dialysis sessions.
Well, we have seen, Dr. Lloyd, you have responded to the questions asked by Dr. Urasa, that would it be possible for similar camps that was done in Kenya and Rwanda to be done here in Tanzania at LMC, Arusha Lutheran Medical Center. Dr. Lloyd.
Yeah, so I think the key is in any organization, there needs to be a general surgeon who's interested in doing vascular work or AV fistula. So that is something that I have found, because if you can't force people who are not interested in doing AV fistula to try and learn, and that will definitely not result in good outcomes. So people who are interested, I see come in, get to learn the work, go back to their hospitals, and then do the AV fistulas. And not only that, experienced people, they really don't need much time to actually do the fistulas. And once they go back, what happens? If there's a residency training, the juniors get to actually assist, get to know all the procedure, the preparation, the pre-op, the rounds, the post-op rounds, the assessment of patients, that's most important. Everything is done over a period of time, and all the residents learn. So I think it's a really good thing if somebody in the hospital, that is one of the general surgeons, has an interest, and definitely we can take it up. There's no dearth of centers that he can go to, like especially on the Arusha is not difficult. Come into the Kenyan side, attend one of those camps that we can from now organize and then learn. That's the same way that Dr. Ronald is doing in Rwanda, and even Dr. John is here, who can actually give a first-hand experience of his experience with Dr. Jerry in the camp. And now the issue is in Rwanda we actually had no EV fistula, no EV fistula being done. We had a French team who would come. So that is one model, a team that would come do the fistulas and go back for the last 10 years. It's been going, but there was no surgeon who was trained. So that was actually a big drawback for us. So there was no interested person. But then we're very fortunate now that Dr. Ronald and his colleague have actually taken up now, and with Dr. Green and Dr. Dijong, and so and they've done quite a few fistulas now, and I'm sure now he'll go independent, and that will be a big break in Rwanda where we can actually straight away send patients for fistula. So that's one. So one model is just coming and going and doing it and going back. The second model is coming in, training the local people. It takes at least 25 to 50 fistulas to really be good at those fistulas. From my point, as a non-surgeon, I would say, from my past experiences, and of course the good people, of course the people who've done vascular work would pick it up. Just watching a couple of them and doing a few. So I think it varies from surgeon to surgeon. And the second model is training the local people. And I think the third model, what we do is, because we have shot a surgeon in Rwanda, in Tanzania, Dr. Moses and his colleague Dr. Alex, they travel from Dar es Salaam into to ALMC. They travel into Mwanza and do the fistulas, stay there for about a week, and then come back to do the fistulas. And this occurs about once in 3 months. So this is one model that we have been following. But I think the key is, as Dr. Francis mentioned, we need to get hold of general surgeons who are interested in doing this, and then go from there. Of course, there is also another big advantage in that we can get funding from the International Society of Nephrology if we have good African surgeons, good surgeons who are in Africa, especially East Africa, and interested general surgeons can actually be paid for about 3 to 4 months to go and stay there and learn and come back. So this opportunity is there. If there are people interested, please let me know. I would be happy to help out. And because I think the more the surgeons we have, the better the patients benefit across the board, and especially outside of the big cities. That is the key thing, and that's what we have actually achieved both in Rwanda and in Chogoria, where it's far from Nairobi and far from Kigali. And so, these people don't need to travel and do it. And of course, also the surgeon, once trained, can also come in to the bigger cities where vascular access surgery is not available and can be done. So there are different models of going about, but I think the key is getting more and more people involved and training, get the training going. Thank you. So at ALMC, I think it's a good idea. It's an interested general surgeon. I'm sure we can help out in many ways, in more than one way, to actually make sure that he gets an exposure, and then he can come back and do the fistulas. There are a lot of patients who need the fistula. In fact, we were just looking at yesterday. There are about 10 patients, about 9 patients who need AV fistula in ALMC. That is accumulated over the last 2 months. And so we would like Dr. Moses to come back and do it. So at that point in time, again, that's an opportunity for the residents to actually assist Dr. Moses when he comes, because then they get an exposure. But I think more importantly, they should also learn how to evaluate a patient pre-op, see, choose that particular vein, see how ultrasound is done, and then go from there. And so I think we have the experts here, so I don't have to talk, and Dr. Jerry and Dr. Green would actually speak on that.
There's something wrong with medical teaching these days. I think, Lloyd, I think you are as old as me. You probably was you're a medical student in the 1970s, like myself. The kind of medical practice we're being prepared to practice on exit from university for the first time undergraduate is different from what they are doing today. I think there has been an invasion of specialties and subspecialties to such an extent that you find the doctors who come out, I think you all agree with me, the doctors that come out of medical school today, they are not as competent as the doctors of our time. I mean, it is surprising to me that a general surgeon has got to be trained to do vascular. I mean to tie a vein to a vein, and a vein to artery. Now I think I don't expect, of course, during my time in the 1970s and early 80s, that time there was almost no dialysis to talk about in Africa. But now there is dialysis everywhere, and therefore I would like us to revisit the kind of medical training that's being done. I don't know at whatever level you start, but I think residents, a general surgeon who's coming out as a general surgeon should be able to do fistula. Why I'm saying this one, I think Makabe should listen, because there is a harmonization of teaching in medical schools in East Africa. That's in Kenya, Uganda, Tanzania, in the East African region, to go by the same standard. I think we should start lobbying so that on exit, maybe after MMed, for surgeons, or even for the other, the residents actually, they should be able to do some, some fistula surgery. The reason why I'm saying this, me on exit from the university, I was able to do almost all the surgery, and at some stage it became actually necessary. After I had done my exit from internal medicine, I had to do some surgery for something like 10 years. And I don't think I was a very bad surgeon. I accumulated that experience during those 10 years. So I think now that we're having dialysis, and it's likely to keep on increasing, so that you find almost all district hospitals in the future we are going to be having dialysis units, and patients will be requiring fistulas. I think before we even rush, we should do it simultaneously. The development of transplantation and fistula surgery. This should be a strategic plan. In fact, I had invited our Minister of Health to attend. I hope he is online, and the one in charge of human resource development in our Ministry of Health. I'm going to give a feedback report if he's not attending to this. It is something very to think seriously about, because dialysis, it is actually a treatment of the future for diabetics and hypertensives. Before the time, or until the time we shall be able to make artificial kidneys.
Dr. Green, Dr. Jerry, would you like to talk about how you all went about the camps that you all went through? How did you assess, and what was important there, and what are the pitfalls that you had, and how we can actually make improvements on the pre-assessment and the post-op care?
Okay, all the remarks that have been made about sustainability, the one thing I'd like to say is for every active hemodialysis unit, you need to have a surgeon attached to it who can perform procedures. Not that that person might not be on vacation once in a while, but generally one person that they can send patients to, or come and look at this arm, or whatever it is. You need a problem solver on site. That's a goal that is reasonable and sustainable. And spending a week with that person, even if it's just one person learning, that's a week that is going to pay off in the long run. Some very specific things. I have a little list here I'd like to go down. These are more specific things relative to the surgeon, Joel, and I'd be happy to have any surgeon there. I'd be happy to have your feedback. I don't mind telling you where we made mistakes. We did find out that vessel loops can be re-sterilized with steam repeatedly. So that's a good thing. We were using eye spears, ophthalmic eye spears, as sponging for AV fistula surgery rather than neurosuction or something. And I wonder, Joel, if you have found something that's more sustainable than that in Africa, because those things are expensive. I relearned again how using a outflow vein less than 3 millimeters in diameter is risky. I'm talking about intraoperative diameter with a dilator, being sized by a dilator. Less than 3 millimeters is risky, and less than 2.5 is foolish. And I made that mistake at least twice. We did find, to my pleasure, even though the regular OR table arm boards don't seem to be of much use, one of our students, Dr. Mark in Chogoria, he figured out that you could slide two of them together on the rail next to each other and make a very serviceable and more stable operating platform. So that was a very happy thing to discover. I found that some operators prefer to avoid magnification, and we used heparinized saline and papaverin drops, both applied from a off-the-field source. So we would mix up 10,000 units of heparin in a liter or 5,000 in 500, and that could be used for multiple procedures on the same day without contaminating the bottle. The papaverin, which we used in dropper form on the vein, we drew up a 2 cc vial, and that would usually last us through the day, whether we did 3 or 4 or even 5 procedures. The circulating nurse running those. We found lidocaine with epinephrine better than plain epinephrine, cut down on a lot of nuisance bleeding. Some people may not agree with that, but that was no one disagreed with it at our place. The importance of flushing and being certain that the outflow vein could take heparinized saline without resistance cannot be overemphasized. And the importance of a final flush of it just prior to the last few anastomotic sutures was something that we had to relearn. Sounds silly, but most people like to sit on a stool with wheels rather than without. There's some danger of an old guy toppling over either way. Fortunately, that didn't happen. And we found that students acquire skills with the Castroviejo needle holder at different rates, and that some students seem to perform better when they were not so closely supervised. This was a surprise to me. I thought I'd be supervising every operation stitch by stitch, but it didn't turn out that way, and that was for the better. So we were able to run 2 rooms. Sometimes I'd be scrubbed in 1 room or even going back and forth between 2 rooms. And that worked out very well. And clearly one of our students was better with very little supervision, and he just took off flying. We did have Surgicel available to us, which we didn't use routinely, but it was very helpful to have in certain circumstances. Most patients were cooperative with local only, though there were a few times when IV sedation was very helpful, but for the most part, we didn't use it. I came bringing what are called bona colta eye forceps, and I go away thinking that jeweler's forceps with the real pointy needle kind of tips may be better and less traumatic to the intima. Joel, you mentioned the volunteer organizations. MAP International has available sutures for missionary work, including 7-O-proline. Each missionary or volunteer or applicant can request it once a year, but it's practically free, and you can get literally thousands of dollars of suture for free or a $65 fee or something like that. And then your volunteer brings it into the country. So Googling MAP International Mission Pack, those are the words that the volunteer has to go to apply. And they need about a month lead time. MAP International Mission Pack. We taught a standard technique of end-to-side anastomosis with 1 knot at the heel and 1 knot at the finish. And we also mentioned all the other ways, but we drilled down on that technique. abandoning the wrist and going to the antecubital space at the same procedure, it especially makes sense in Africa, especially if you don't have a good preoperative ultrasound map. We did this once where we had marked an alternate vein, and we probably should have done it at least 2 other times. Whether the antecubital patient should be splinted in extension overnight is your call. I'd be curious to know what you do about that. We splinted them all in extension with plaster, with a plaster back slab overnight. And at home in the States, we use a knee immobilizer, and we can't keep these patients overnight. At Chogoria, we had the advantage of keeping the patients overnight and seeing them the next morning. And finally, if you want to find online that Chinese vessel suturing kit, if you Google suture practice blood vessel, if you search on those words on eBay, Joel, suture practice blood vessel, those words will take you to the $11 kit, and then maybe you can bring them in with you. If people had that in advance, it would even help. And as Dr. John Kanye pointed out, we use these with the general surgery residents in Kijabe and in Latane, and the young people, they take to this Castro very nicely. It's the old timers that have trouble learning it.
Well, thank you, Dr. Jerry. That is a wealth of information. I was hurriedly taking notes on everything you were saying. I'm familiar with MAP International. They've provided me with thousands of dollars worth of suture and even surgical meshes and things like that. Right. I've even found that they'll sometimes give you 2 sets a year if you ask nicely.
Oh, okay.
Yeah.
Thank you.
As far as some of your questions and my experience, I didn't use anything but a typical Raytech type sponge.
Okay.
I didn't use eye spears at all.
Okay.
We did have a fine suction availat and that was nice.
Mm-hmm.
But I didn't find the need for those expensive eye spears.
Okay. Good.
We have at the mission next door to our hospital, we have some skilled carpenters, and we've had them make a wooden arm board.
Smart.
That's wide, and it just has a piece that slides under the main mattress on the operating table.
Right. That's all you need. Yeah.
Yeah. And then we put a pad on that underneath. We did not have access to heparin, and it may be available in the country, but expensive.
Mm-hmm.
So I really like your idea of making one batch of heparinized saline that you can dispense as needed. I hadn't thought of that. What we did was simply flush the vessels with saline, sure. And then make sure to back bleed to remove any clots, right. Before actually opening the fistula. I don't use any splints. I don't do that in the US or in Africa, and we have not had issues with that. I right. educate the patient on not keeping their arm tightly bent after an antecubital fistula.
Right.
But I have not found any to clot off because of what I perceive to be a misbehaving patient with bending their arm. Mm-hmm. I can't overstate my experience in the US and in Rwanda has been so good with blocks. If you use a peripheral nerve block, like a supraclavicular block, it's not a very difficult block to learn if you even have to do your own anesthesia. Mm-hmm. But the CRNAs and the anesthesiologists that we work with in Rwanda were quite skilled at a supraclavicular block, and it makes the vessel so much bigger. It really helps. I will second all of your comments about selecting the vein, needing a vein to dilate nicely to accept a heparin flush. If it doesn't, you're sure to have a clotted fistula the next time, and that there's nothing more disappointing.
Yeah.
So I think I like your idea of if you have to go in without an ultrasound, exploring the wrist first, and then exploring the antecubital fossa as well, and just finding a vein that flushes nicely and expands with a good flush. So those are my experiences. And as far as some of the materials you're talking, equipment you were talking about, we bought some Gerald forceps, some fine vascular forceps that right. they weren't too expensive. You can find some low cost ones. I don't know how they're holding up, but for the first few trips, they've worked well.
Good, good.
So thanks for, I enjoy hearing your technical advices, because that's definitely the things we're troubleshooting now.
Wow, thank you. That's very good experience. Yeah, we are learning a lot from you, especially the majority of this audience from this session are nephrologists and MDs. So it's good that we are learning from you, the experience that you are giving us. Yeah, so there is one comment here. I would like to thank Dr. Ronald. We started to figure out how we can help our dialysis patients with AVF creation as only the best form of long-term vascular access where the long-term renal replacement therapy is difficult, like our country in Rwanda. So it's just a compliment to Dr. Ronald. Okay, so I think as you clearly pointed out, in Tanzania, for example, as Dr. Francis said, we have few surgeons who are doing that, vascular surgeons. We have few in Dar es Salaam, few in Dodoma, and none in around the lake and in northern zone. So we need to create a platform where people can come and learn. We have very good experience in nephrology, where in the past there is, there was a program which was initiated in Dar es Salaam at Muhimbili, and a lot of nephrologists were trained through that program, including myself and even Dr. Francis, who commented earlier. So if we can create something like that in East African countries, where we can have partnership with hospitals, in America, in India, or even within East Africa, in Kenya or Tanzania, where surgeons can come and learn in a long-term basis, like 6 months. Then when they come back, they come and transmit that knowledge to other people. I think that's going to help a lot. During the camps, like Dr. Gel and Dr. Green, you are doing, also that one, complement the efforts of making sure that we create a strong vascular surgeons who can, create fistulas in our areas. So we will need to have something like that in our country, in Tanzania. We have a lot of surgeons who are interested once they get information, and I think that will be the starting point. And again, I come back to, to agree with Dr. Jerry that, every dialysis center, every hospital needs to have someone in place who can do the fistulas. That's going to help a lot. And, because now the cost is very high. In Tanzania, for example, the cost of doing AVF fistula is around $450, equivalent to 100 million, 1 million in Tanzanian shillings. So most of our patients can't afford. But for sure, the cost will come down once we have so many surgeons distributed around the country. So that's what I could comment regarding your presentations. I would like to hear comments from others. Any other comments? There is Dr. Joyce say, can anyone comment on the availability of supplies for purchase in African countries, like 7-0 chlorine, suture, surgical instruments, celastic vessel loops? Anyone who can comment on that? That's a question posed by Dr. Joe.
Yeah, I think Dr. Neil, if you can actually give us this, we can actually try and source it from various regions and see what exactly is needed. The essential stuff we can actually source, and we're looking at papaverine. I think we will get it in a little time. We've been chasing it. It's a question of importing it now with the registration, so I think we will get it in a few weeks' time. And once we start getting it, then it will be a regular process. So this way, if you can actually give us the list of material that is required, we can definitely have people look at it, look for it across Tanzania and Kenya, and get some stocks and keep it for the camps or for the event business.
I think that would be very helpful. For now, when it's just a camp or just a volunteer coming and doing some and doing some training, it's sustainable to bring supplies with us. But as the local surgeons begin doing and start to do several hundred, over the course of a year or two, the supplies coming from outside the country are not going to sustain that size practice.
Yes, and thank you for bringing it up. Thank you for bringing it up.
All right. Any other comment?
Dr. John, Kenya, would you like to actually say anything? What should a surgeon wanting to learn AV fistula, what are the essential things that that he needs to go through or he needs to know, or what if you can enumerate your experience in trying to get through AV fistulas, so it will be a learning for the others as well.
Well, what I can what comes out on top of my mind in terms of learning how to do AV fistula is that there was Dr. Joseph who talked about the kind of training that people are coming out through. Most of the time when you are doing a general surgery residency training, even when we are doing our general surgery residency training here at AIC Retain, the number of patients requiring a vascular anastomosis is not that great. So the numbers, you usually find the numbers are pretty low. And after you've gone through the residency program, now the residency programs have increased numbers of residents trying to train. Trying to teach them to do vascular anastomosis might be a difficult project. What you've been doing, the one that Dr. Jerry is talking about, was doing sort of like having a skills lab in those facilities to be able to train the general surgery residents in doing vascular anastomosis, especially for small vessels. It was easier, I think it's easier being a general surgeon to do the fistulas because you have some experience and you've seen those procedures being done, and you probably have done maybe one or two. Now doing it in bulk becomes easier when you're doing it in a camp format. The thing that I liked about Chogoria was the number of patients. The number of patients requiring the operation was overwhelming, almost like 50, 60, 70 patients who wanted to be done, but the people I think who qualified were like 30. So organizing them in camps might also be a way of doing them, so that not only do you teach the surgeons or refresh their memory for those who did their surgeries a long time ago and they have not been doing the vascular anastomosis for a while, refresh their memories in terms of operating and doing vascular anastomosis in a camp setting. And I agree with Dr. Jerry's remarks that, yeah, most of those places that you have a dialysis center should have at least one or two surgeons who know how to do the AV fistula and AV fistula well, doing them well. It's one thing just to do AV fistula, but you have to do them well so that they are patent. In terms of sutures, I think in Kenya we can get the sutures, even the 7-0 Prolin sutures. Sets is another issue, getting the particular instruments for the set. So that's something that you might need to look at. Getting the sets components might be a challenge in African countries, probably in Kenya, Uganda, or Tanzania and Rwanda. Getting the individual instrument might be a challenge. For us, I think this is something that we are starting our dialysis center at AIC Retain, so I'm hoping we'll see increased numbers. We've been sending like 2 to 3 patients to the capital for AV fistula, but now I think we'll be able to do that. I think Dr. Jerry was my teacher. I think I graduated well, and I hope he has confidence in that we'll be able to impart that information and that knowledge to the general surgery resident and even to the other general surgeons around whom we work with. The county that I work in, Kenya is divided into counties, has over 15 general surgeons. So if some of them who are interested can come to a facility, we'll be able to train them also. Thank you.
All right, thank you. Dr. Lloyd, you wanted to comment something?
I think we should develop 1 or 2 centers where we can have visiting surgeons. Like now we have, just now here we have Dr. Bonnet from Rwanda, who can actually come to Kenya, and the ISN will actually pay for that entire trip. You know, for if you anywhere between 3 to 6 months you can spend in Kenya if you want to learn AFS stuff. So so that I think it'd be really great if we can put up something in Lutheran, in Chogoria, you know, and in Kijabe. You know, over time, I'm sure in about a year or 2 we can have centers which can actually train, and funding is available for people who want to come, and it's not difficult. They do give funding, actually they had given one of the surgeons from Tanzania when we applied, but he couldn't go because of COVID. So, so this just wanted to highlight that. Thank you.
All right. So I think I would like to get some last comments from Dr. Joe and Dr. Jerry. Before Dr. Wala?
Yeah, Dr. Wala is there. Dr. Wala?
Yeah,
Dr. Wala?
Hello, Lloyd. Hello, how are everybody?
Good, Dr. Jonathan. Can you, any?
Hello?
Okay. Hello, Dr. Wala. Yes.
Yes. It's been an interesting conversation. Gotten many insights from the speakers. We are facing the same problem in Kenya, as Lloyd has pointed out when he has been in Chogoria, and soon he'll experience the same in Kijabe and the rest of the places where the AHN is happening units. The main problem is having an AV fistula champion, and that has to be led most of the time by a surgeon, which may be what Dr. Ndarindo has talked about, the curriculum pertaining surgery. Obviously, it should involve part of work in AV fistulas and other vascular work. However, most surgeons, even the urologists who have got some training in this, they are rarely interested in continuing, maybe because the remuneration is quite low, maybe because it interferes with most of their core business. And therefore, maybe it may be for us as nephrologists also to train ourselves. Being physicians, we have trained ourselves in fixing tunnel catheters, etc. I think there are many countries where the curriculum for nephrology involves also doing interventional nephrology, including vascular work. And maybe more of our younger colleagues can take up this, so that it can be the nephrologist who's championing vascular access development in dialysis patients, or in pre-CKD patients even. Thank you very much.
Thank you, Jonathan. Very good comment. Yeah,
you know, the very, very right comment, because you know, on the Indian front, we've had actually a few American nephrologists who were intervention nephrologists and also got to doing AV fistulas. And they came and started this about a few years ago. Right now, I think there are a number of Indian nephrologists who actually do a lot of AV fistulas, all types of AV fistulas, plus intervention nephrology. So I think it's a good trend if, you know, nephrology, young nephrologists can actually take up this, and, you know, it's not difficult. I know 2 or 3 of them who actually have worked with me now are very, very good, you know, fistula surgeons. And I think it's a very, very good idea to pursue. Again, you get more people who can actually do this work, and then people don't have to wait for long to get it done. So I think it's a good thing to think about. Thank you.
Thank you, Lloyd. Thank you, Wala. That was very good comments. Maybe before we wind up, I would like to hear last comments from Dr. Joe and Dr. Jerry.
Well, from Lloyd's last comment, I wonder if he's in the next group of students. What do you say, Lloyd?
I wouldn't mind, but I think you should give the younger people a chance.
I share my school with Dr. Jonathan Wala. I think, and basically because we are both from VIT, you know, Division of Nephrology. Johannesburg Hospital. And I think, well, he was almost going to say, you know, they believe surgeons, they are like carpenters and that kind of stuff. And maybe he was going to say, like I was going to, that if it is easier to train a surgeon to do fistula surgery, it's actually much easier to train a nephrologist. That's a joke, huh?
All right. I think if there's no more comments or questions, I think we can wind up here. But before we wind up, we'd like to thank Dr. Jerry, Dr. Joe for very good, you know, narration and experience that they shared with us. I really appreciate your time and everything. Dr. Lloyd and everyone who contributed to this session today. We'll continue with the same session. I mean, with webinar next week on Thursday. So I'd like to thank everyone who joined and contributed, and for those who listened. I think moving forward, we'll be able to take this advice and, you know, make changes in our areas within East Africa and Africa as a whole. So thank you very much and see you next week.